Thank you very much, President Krause. It's a pleasure to be here, and thank you, all of you, for joining us today. So many years ago, I was at a conference in Boston, and it was a mental health meeting, and I was in the conference hotel elevator, and I met an African engineer who asked me what meeting I was attending, and I said, I'm at a meeting focused on mental health in Africa and across the African diaspora. And he looked at me and said to me, my mother died from stress. And he then recounted a life of poverty that she lived, a work day that started before the sun rose and took her to a distant market everywhere, sometimes with money at the end of the day and sometimes without. He remembered being hungry at times and knowing which relatives to ask for food when he needed it. But her life circumstances, he surmised, deeply affected her mental health, which was inseparable from her health, inseparable from her well-being, and ultimately from her life. And we all know this is true. Our human experience shows us that we cannot separate health from mental health, from our general well-being. And the data that our colleagues at the Institute for Health Metrics and Evaluation produce also shows us that when we move along this dimension from good mental health to mental disorder, there are serious consequences. Mental disorders can be extremely disabling conditions, but we also have data that demonstrate their link with mortality due to other conditions, which you'll hear somewhat about today. We know that people with severe mental disorders have a 2 to 3 times greater risk of death due to cardiovascular disease, 2 to 6 times higher risk of death due to respiratory disease, 2 to 3 times more likely to die from an accidental death, 2 to 4 times more likely to die from an infectious disease, are 2 to 4 times more likely to die by homicide or violence. Most of us are well aware of the links between mortality due to suicide and mental disorders. But the point is here that we cannot segment ourselves. Equally as important, our mental health is connected to the social, economic, and political contexts that we live in and that we breathe. The social determinants of mental health, including our access to education, exposure to poverty, to discrimination, to environments characterized by violence, influence our risk and protection from mental disorders. The built environment, the cultural context, biology, all of these influence mental health across the life course, our risk, or our resilience. But at the very heart of this message from the global mental health community is that mental health is about your humanity. Our mental health and our minds fundamentally are an important part of our humanity. And so this is what we want to think about. The Lancet Commission, the Lancet Commission on Global Mental Health and Sustainable Development launched last week in London, as you heard. It outlines a plan for transforming mental health that takes into account the complexities of the world that we live in and helps us see how we can integrate our responses to mental health into the responses that the global community will take for development, and we'll try to transform the world by 2030. So here at University of Washington, we will be a part of that transformation. First, building on the history of innovative mental health care approaches that developed of necessity in the Pacific Northwest. This is an area that many of you may or may not be aware of, where we have limited resources for mental health care. And people have had to think about, well, how do we do this? How do we get care to people that are in need in very remote areas across this region? The goals of our global mental health program are to reduce the burden of mental disorders in low resource settings around the world through innovative research and training, collaborative partnerships, and through the translation of research to inform policy development and advocacy. And we want to strengthen and support the integration and application of behavioral sciences in global health. Importantly, we are a part of the globe. We want to think about the mental health of Seattle, the mental health of people in our WAMI region, and the mental health of people around the world. Washington State is incredibly diverse. It's a state that's received a lot of refugees over the last decade, but it's also a state of immigrants, and it's a state of people coming from around the country as well as around the world. One of the other tenets of our global mental health program is that the global community gives us the opportunity to think about learning from each other. This is an image of an intervention called the Friendship Bench, a simple psychological intervention adapted for use in Zimbabwe, now on the left, being used in New York City. So the way that we innovate can happen in multiple directions, and we've got innovations here in Seattle that are going out around the world, and we want to try and see how we can take advantage of those that are being produced in other parts of the world. Technology is going to be a key piece of this. This is a great place for technology, as you've heard, and people are learning to figure out how mental health care can be extended through the use of technology, but how we can also use technology to better understand our various states of mental health. We're excited about working with systems as well here. We build on our international partnerships. We have a strong base in implementation science, models of effective delivery for mental health care, like the collaborative care model. And we have the opportunity to integrate mental health into different platforms, using different kinds of providers in different contexts, depending on what the resources are there, and learning how and where technology adds value to really develop systems that deliver care efficiently. So today's an invitation to join us, to collaborate with us as we put our minds together to figure out how best to move the global mental health agenda forward. So thank you.